So I'm going to talk to you about, we're probably going to start with one of the toughest things that we as strabismologists have to manage, which is the third nerve palsy. And yeah, there it is, which is the third nerve palsy. And I'm going to talk about a few management strategies that we use in these cases, and essentially the challenges. So we all know that in third nerve palsies, you'll have an exotropia, you'll have an eye in a down and out position, the pupils may be involved, there would be ptosis, so ptosis also needs to be managed alongside with this, some mild proptosis, and you could have associated cranial nerve palsies, which just kind of makes it more complicated or makes the system more difficult. This is what a complete third nerve palsy would look like, a ptosis, a down and out eye, you can see the pupil getting involved here, and the issue with these cases is because of the involvement of multiple muscles, we have a challenge as to how to tackle them. In nuclear third nerve palsies, you can have ptosis bilaterally. The other eye, contralateral superior rectus, may also be involved. The pupil may sometimes be spared. So within the third nerve palsy also, you've got individual cases that you have to look at. You could have a partial third nerve palsy where you've got recovery of some of the muscles or non-involvement of some of the muscles. And then you've got aberrant regeneration, as you can see in the pictures below, where on adduction you can see that the ptosis is getting corrected in the eye. So these again are situations which are unique and which need to be tackled with. As I said, it's primarily multiple muscles getting involved, so you don't really have that much scope to operate or look at. There is ptosis, there is diplopia, and this can be tackled to some extent non-surgically, but in most of these cases, if there is no recovery or partial recovery, you would require a surgical intervention to correct it. In terms of medical therapy, you've got prisms for small deviations. You can use segmental occluders or occluders to control the diplopia. And of course, one good part sometimes is that the ptosis prevents the diplopia from happening. So your patient actually may not be that bothered as compared to other nerve palsies, at least in the beginning, till some recovery starts to happen. Chemodenervation, we all heard very well from Dr. Saurabh now, so we can use botulinum toxin here. We're going to use it on the lateral rectus muscle, which is the antagonist of the medial rectus that we are treating. So you could do it in just the fashion that you described it earlier. Surgical therapy essentially would be done after at least 6 to 8 months, once it has stabilized, the deviation has stabilized, and the purpose or the aim of it is to actually get diplopia-free area in the primary and down gaze, and also correction of the ptosis to some extent. And it is challenging, as I've said, because of the involvement of multiple muscles. And the various options that we have is to weaken the antagonist muscles, as we can see here is the lateral rectus that's there, or the superior oblique, or strengthening the agonist muscles or the paralyzed muscles here, or you have to do a contralateral eye surgery as well, sometimes in aberrant regeneration. I'll show a couple of cases of that as I go along. And you can do transposition procedures as well. You can transpose the lateral rectus towards the medial rectus, the superior rectus, and again, these are on a case-to-case basis. And I'll come to some of these indications just down the talk. In incomplete third nerve paralysis, you can use, depending whether it's in what muscles are involved, whether it's a superior division or an inferior division, you can choose your surgery. So this is just a picture there to talk about various options that we have. But in essence, the basic principle remains the same. We want to weaken the antagonist and strengthen the yoke muscles that are there. And specifically in aberrant regeneration, we often have to touch the other eye surgery as well. And in complete third nerve palsies, after we've all done all this, we also have to do a ptosis management. And here we need to look at the LPS action, we need to look at the Bell's reflex, and only then we can go ahead and lift the lids, which could be done by a sling or a resection or a plication based on how much ptosis there is. So, and of course, along with this, you need to manage other aspects as well, any other nerve palsies, dryness, dry eyes that have happened, the pupils, you need to give miotics, you need to give near-ad. So all those also come part of the third nerve palsy. So it is in fact a more complicated affair, as we can see. So let's look at this, a case of partial or incomplete third nerve palsy. You can see that there is an exotropia, and here we can get away with the resection procedure. And remember, we want to do a supramaximal recession now of the lateral rectus, because we want to weaken it substantially, and not just what we see in the comitant squints that we so far are treating. Now, in cases of aberrant regeneration, as you can see in the picture above, where there is an adduction and the ptosis improvement, you need to operate the contralateral eye, and that's a discussion you need to have with your patient. And you can see here we've done the left eye lateral rectus recession, and that has actually corrected the ptosis along with correcting the exotropia. And here's another case with a similar kind of an outcome. Again, these are cases you need to discuss with your patient, and you need to explain to them why you want to do the normal eye, which is not usually the eye that we are that is actually affected. So as far as he's concerned, you're doing something which is different. You can also correct the vertical deviations that may happen with a shift of the horizontal recti muscles as you're doing a resection in them, as you can see in this case, and that also corrects the vertical deviation. In complete third nerve palsies, such as the one here on the left, you can see full ptosis, eye in down and out position, no movement whatsoever. You have an option of anchoring the globe to the medial wall or the periosteum in the medial wall as well, along with the recession of the lateral rectus. And you can get good alignment in primary, but there will be no ocular movements after that. Here's another case, but not necessarily in all cases does the globe anchor work very well. As you can see here, that there is a residua that is remaining. Another option that we have is to do a lateral rectus periosteal anchoring, and that's actually a severe form of weakening of the lateral rectus that is there. And you can see that we're getting a good correction in this case of right third nerve palsy after doing a lateral rectus periosteal anchoring and strengthening of the medial rectus. But as again in this case you can see, there are times if you have not done the anchor very well, or some part of the lateral rectus is still touching the globe, or you've not been able to separate it or compartmentalize it from the globe, you could actually end up with an undercorrection. But these are expectations that you have to explain to the patient and the family beforehand. And that's also one of the important conclusions that we'll have at the end of this talk. Here is a case where you're going to be seeing that there is a very large angle exotropia because of the third nerve palsy, and we are seeing that we've done a transposition of the full tendon lateral rectus as well. And though here you could see the result was less, but if you come to this case here, where we've actually done a split tendon transplantation with a posterior fixation suture at the back, we get a much better result in the long term, and you can see such a large deviation getting corrected. So now transposition procedures are also gaining popularity, and this is something we're doing more and more, as we know that lateral rectus is one of the only functioning muscles left after in cases of complete third nerve palsy. This is a lid sparing third nerve palsy, and you can see again we've done a tendon transposition, and you can choose to do a superior or an inferior route for a full tendon, or you can do a split tendon transposition of the lateral rectus. And so this is the idea of this talk, is just to sensitize you with various management strategies that we have. And as was discussed with the previous speaker, when you don't have one good strategy, then you have many strategies that come about in play. So this is again a case of third nerve palsy. Now let's look at the conclusions. So one, we have to look at whether it's a complete or incomplete third nerve palsy. We have to see if there's any aberrant regeneration. We have to see if the patient is willing to operate the contralateral eye in those cases. But most importantly, we have to establish the expectations. We have to let them know that these are cases where there will be undercorrections, sometimes rarely overcorrections as well, and that the ocular movement does not come fully, as you had seen in all those 9 cases, despite a full surgery. And it's only after that that you plan your surgery on an individualized manner and you proceed with that. And do remember that you also need to manage the pupil, you need to manage their near vision, you need to manage the ptosis, and that too can be done with the support of your oculoplasty colleagues or yourself. And in those cases, make sure that there is a decent Bell's reflex and some amount, and the eye does not end up with a dry eye or an exposure afterwards. Thank you.
Thank you, Digvijay, for the wonderful overview of third nerve palsy.